Hey everyone, my name's Alex Like, and I'd like to welcome you back to Paramedic Pathophys here on EMTV. This segment is designed to provide a quick rundown on the pathophysiology, physical findings, and treatment for common medical complaints and emergencies. Keep in mind, for the sake of brevity, I'm only sticking to the high points. So sit back, relax, and let's talk about pneumothoraces. So what is a pneumothorax? Well, a pneumothorax is the presence of gas or air inside the pleural space between the lung and the chest wall. So what does this look like? Well, in normal breathing, the diaphragm contracts, pulling downward, creating a negative pressure within the pleural space which allows the lungs to fill with air. In the case of a pneumothorax, there's a disruption to the lung's integrity, and air is allowed to fill this pleural space. As you continue to breathe and the diaphragm contracts, more and more air will fill this pleural space, causing the lung to collapse further. This portion of collapsed lung does not allow gas exchange to occur, as the alveoli contained within it are rendered effectively useless. So what causes a pneumothorax? Well, a pneumothorax can be caused by blunt or penetrating chest trauma, or even from the effects of overpressure that you would see in instances of explosions or building collapses, or even rapid ascent during scuba. Pneumothoraces can also occur as a result of several chronic medical conditions, such as emphysema, where the tissue within the lung itself becomes weaker and more friable, making it more prone to developing these disruptions in its integrity. And then for some individuals, particularly those with a history of Marfan syndrome or connective tissue disorders, they can develop pneumothoraces spontaneously. Now, small pneumothoraces can actually heal themselves and require very little intervention. However, in certain situations, a simple pneumothorax can actually develop into what's known as a tension pneumothorax. A tension pneumothorax is defined as when the air pressure within the pleural cavity exceeds atmospheric pressure. This is considered a medical emergency. Now, it is important to remember, though, that tension pneumothoraces are much more likely to develop in the cases of a closed pneumothorax, as opposed to an open pneumothorax, in which you would have a sucking chest wound. Now, there are several common signs and symptoms or common presentations of a pneumothorax. These are the obvious chest pain, shortness of breath or dyspnea, tachypnea, cyanosis, the use of accessory muscles to breathe, a VQ mismatch or a ventilation perfusion mismatch, in which part of the lungs are able to receive blood but cannot effectively oxygenate that blood, hyperinflation of the affected side of the chest, hyperresonance during percussion to the affected side of the chest, which will sound a lot like a drum if you tap on the ribs, hypotension, particularly with tension pneumothoraces, the presence of JVD or jugular venous distension, again, typically only seen in a tension pneumothorax, and tracheal deviation to the unaffected side of the chest. This is a late sign and typically only seen with a tension pneumothorax. Now, as I had mentioned before, a tension pneumothorax is a legitimate medical emergency and requires prompt intervention. The reason that we see some of the signs and symptoms, such as hypotension, jugular venous distension, and tracheal deviation in a tension pneumothorax, is because as the pleural cavity continues to fill with air and compress the lung tissue down, the mediastinum, which contains the heart and the great vessels, will begin to actually deviate across the midline. In doing so, venous return to the heart is limited, causing a significant reduction in preload and a drop in overall blood pressure. The venous return to the heart is also impaired through the jugular veins, leading to jugular venous distension, which we can see externally. As the mediastinum is pushed further across the midline, we will see tracheal deviation. But be aware, at this stage in the tension pneumothorax's development, the chances of the patient surviving are extremely low, and without prompt treatment, this patient will die. Now, despite how dangerous this condition is, closed pneumothoraces, whether simple or tension, can be treated quite simply. First, we'll provide our patient oxygen. We'll then perform a pleural decompression, and this can be done in a variety of different fashions. However, pre-hospitally, the most common method of pleural decompression involves placing a 14-gauge angiocatheter or decompression needle in either the second or third intercostal space at the midclavicular line on the anterior chest. You can also perform a needle decompression lower at the mid-axillary line at the fifth intercostal space. As we are primarily decompressing for air though, air will tend to go upward in the pleural cavity, so decompressing in the superior portion of the pleural cavity makes a lot more sense for air. Chest tube placement is primarily done lower at that fifth intercostal space in the mid-axillary. And remember, if your patient's awake during this process of pleural decompression, at least consider administering some sort of analgesic or sedative prior to the procedure. Once decompression has been performed, the air pressure within the pleural cavity should return back to normal, and the heart will return to midline, returning preload to normal volumes and hopefully improving cardiac output. Further management of this patient may involve additional airway management. Alright, and that's a quick rundown on the pneumothorax. Thank you for watching Paramedic Pathophys here on EMTV. Please remember to like and subscribe to my channel for more videos. And please leave a comment below to tell me what you'd like to see for future videos or what I could do differently. Until I see you next time, stay safe and keep washing your hands.